this. But in any case, he got his master's in social work before going on for a PhD at University of North Carolina. And then he, shortly after getting his PhD, took a 2-year wandering a little bit, but to a different university. Then he ended up at University of Utah, where he now has a distinguished endowed chair. And he's, which is impressive to be able to get at this point in time. So very nice work. And obviously part of that is he's had an impressive amount of grants, mostly a lot related to mindfulness interventions. And some of the presentations, they commented about social workers doing the delivery of mindfulness, because that's was a better approach than sort of having a trained mindfulness, conventionally trained mindfulness person. And besides all the grants, this was an impressive number of publications here. It was like 200. It was more. It was scaring because you didn't have as much time as me, and you beat me by a fair number here. It's an impressive number of publications here, and a lot of them were related to mindfulness, but just other areas too. And of interest in his background, when he was at University of North Carolina, he was on their T32, both as a I just found out this morning. He was a T32 pre-doc as well as a postdoc there in their T32. So he understands T32, and he's been very successful. So another highlight, another role model in some sense for people who are. So again, Eric, thanks again for being willing to do this. And I keep looking at the computer, but you're not there. So I don't know exactly how to, I should turn back to look at you. Maybe I'm looking at you now, I don't know.
You see me?
Anyway, thanks again, Eric, and I'll turn it over to you now.
Thank you. Can you hear me okay?
Yes, we do. Yes.
Okay, great. Well, it's an honor to be presenting to you today. I've been aware of your T32 program for a long time now, and I hold it in great esteem. It's one of the best integrated medicine T32 programs in the country. So today I'm going to be speaking with you. Sorry, there's a bit of an echo in the audio here. I don't know what's going on with that. Maybe can you turn a microphone off on your side?
It might be the recording.
I would turn the room mic off while I'm speaking. That might help.
Yeah. I think it might be the recording.
Yeah, it might be because
Because we're recording on a second.
Try to.
Hold on a sec, we're thinking.
Which ultimately leads to the loss of self-control over opioid use that's characteristic of opioid addiction. But we know that not all patients who are prescribed opioids misuse them or become addicted to them. In fact, most don't. So it's an interesting scientific question. Why can some patients go on to take opioids as prescribed, whereas others start to misuse opioids and become addicted to them? And answering this question has motivated a great deal of the basic science research that has informed my treatment development research program. So one of the ways that I attempt to answer this question is to use tasks from cognitive neuroscience. And one of the tasks that I tend to use in my lab is called the dot probe task. In this task, there's a computer screen and it's split in two. On one side of the screen is a pain-related image. On the other side of the screen is a neutral image. These images are displayed for a very brief amount of time, about 1/5 of a second. It's just a flash, after which the images disappear and a dot pops up. And the participant's task is to choose the side with the dot with a button press. The computer measures reaction times, and it turns out that there's a large body of research to show that people with chronic pain are faster to find the dot when it replaces the pain-related image than when it replaces the neutral image, indicating that they have this attentional fixation or attentional bias towards pain-related information. We also pair neutral images and naturally rewarding positive images, and we pair opioid images and neutral images. And about a decade ago, my research group was the first to demonstrate that people with chronic pain who had an opioid use disorder were faster to find the dot when it replaced the opioid image than when it replaced the neutral image, indicating they had an attentional bias towards opioid-related cues. And this opioid attentional bias had significant clinical consequences. It predicted opioid misuse 20 weeks following the end of behavioral treatment. So these data support the notion that opioid misuse is linked with increased sensitization to opioid-related cues. But in my lab, we also measure hedonic dysregulation with another task called the emotion regulation task. In this task, participants are presented with emotional images. In response to negative emotional images like this mother and child screaming in fear, participants are asked to either view the image or to reappraise the image by reframing the meaning of the content of the image in such a way as to decrease its negative emotional impact. So to reappraise this image of this mother and child screaming in fear, one might think, the mother and child faced the tragedy, but in facing the tragedy, it brought them closer together as a family. And thinking about this image in this way might reduce the negative emotions that it elicits. In response to positive emotional images like this father and son at the beach, participants are asked to either view the image or to savor the image by mindfully focusing their attention on what is pleasant, beautiful, and good in the image, and appreciating and amplifying any positive emotions or pleasant sensations in the body that arise during the savoring experience. And during this task, we measure an array of psychophysiological processes, including heart rate variability, which is the beat-to-beat variation in heart rate that is largely driven by the parasympathetic nervous system and governed by a high-order network of brain structures involved in regulating attention and emotion. So a number of years ago, my colleagues and I found, relative to people who take opioids as prescribed, here depicted in these blue bars, opioid misusing chronic pain patients, depicted in the red bars, showed significant blunting of high-frequency heart rate variability during reappraisal, viewing positive images, and savoring positive images, indicating that they have a selective deficit in the ability to shift their emotions in a positive direction. And we find converging evidence with EEG. So here in the top center panel in blue, you can see brainwaves from people who don't misuse opioids. These individuals are able to decrease their brain's reactivity to the negative emotional stimulus by reappraisal. They're able to decrease their brain's arousal. But beneath you can see event-related potentials of the EEG for people who do misuse opioids. Not only can these individuals not decrease their brain's reactivity to the negative emotional stimulus through reappraisal, but actually reappraisal backfires and it aggravates the negative emotional related brain activity. And all the way in the right, you can see brainwaves from during a positive emotion regulation task. So here you can see in blue brainwaves from people who do not misuse opioids. These individuals are able to increase their brain's response from viewing positive images to savoring positive images. And beneath in red, you can see event-related potentials for patients with full-blown opioid use disorder. Here you see total blunting of brain response during positive emotion regulation. And these deficits in negative and positive emotion regulation are associated with higher levels of opioid craving, and they predict opioid misuse in the future. So if this is the problem, if opioid misuse and addiction are linked with and driven by, in part, this hedonic dysregulation, then we really need to understand this mechanism and we need to be able to target it with interventions. Going subcortically, I've done some work with colleagues at Mount Sinai Hospital in New York who've used fMRI to characterize the corticostriatal mechanisms of hedonic dysregulation. And once again, in this study, we found that corticostriatal dysregulation during reappraisal and savoring are associated with higher levels of opioid craving in people with opioid use disorder. So to address this hedonic dysregulation, we need interventions that can simultaneously facilitate both top-down and bottom-up regulation of emotional and reward-related experience. And to that end, I developed Mindfulness-Oriented Recovery Enhancement, or MORE, which is an integrative mind-body therapy that unites complementary aspects of mindfulness training, cognitive behavioral therapy, and principles from positive psychology into a treatment that can simultaneously address addictive behavior, emotional distress, and chronic pain. More is a sequence treatment. It begins with a foundation of mindfulness training, which by virtue of daily meditative practices aims to strengthen attentional control and meta-awareness that can then be used to synergize more elaborate therapeutic techniques like reappraisal and savoring, and ultimately lead towards experiences of self-transcendence, this sense of being connected to something greater than the self. These treatment components are intended to activate a series of therapeutic mechanisms, which are in turn intended to produce clinically significant change in a range of treatment targets relevant to chronic pain and opioid misuse. And I would point out here that more has been tested for a wide array of addictive behaviors, but my talk today is really going to focus on more as an intervention to address the opioid crisis. So more is an 8-session manualized group therapy intervention. Sessions are about 2 hours long. They begin with a formal mindfulness meditation exercise, followed by a debrief and group process, which is just exquisitely important for helping patients to consolidate what they're learning from the mindfulness techniques, and then to apply that learning and generalize it to addressing their symptoms of chronic pain, emotional distress, and addictive behaviors in everyday life. After the debrief, new psychoeducational material is delivered, and the session topics are listed here on the left. Sessions end with an experiential exercise, some sort of mind-body practice that's designed to hammer home the concepts that you're trying to teach. And participants are asked to practice homework consisting of 15 minutes of mindfulness, reappraisal, and/or savoring practice each day. I want to take one moment to focus in here on how we teach patients to manage pain using the techniques and more. So people with chronic pain typically experience pain as an emotionally laden, monolithic, and unremitting experience. It's this terrible, awful thing that always seems to be there. And on top of that, they often overlay a layer of suffering. They say to themselves, why me? This isn't fair. This pain is ruining my life. And this emotional anguish actually amplifies nociceptive processing in the brain. In more, we teach patients mindfulness techniques to remove this emotional overlay and then to deconstruct the pain experience into its subcomponent sensations. So rather than focusing on some terrible, awful anguish, we teach patients to use mindfulness to zoom into the pain experience and to break it down into sensations of heat or tightness or tingling, as well as to notice the spaces in between those sensations where there's either no sensation at all or potentially pleasant sensations right next to the painful ones. And using mindfulness to generate interoceptive awareness and exposure of bodily sensations may help to reverse emotional bias during pain appraisal and thereby decrease pain perception. And we use a very similar technique and more to help patients to cope with craving by breaking the craving down into its cognitive, emotional, and sensorial components. Now I want to take a moment to talk about another technique and more that makes this intervention quite unique. In more, patients are taught a mindful savoring technique, which is depicted here in this beautiful infographic designed by the National Center for Complementary and Integrative Health for the MORE research program. So patients are taught mindful savoring by focusing their attention on a beautiful object. We've traditionally used in face-to-face MORE therapy flowers. So patients take a rose, they focus their attention on the beautiful colors, textures, and scent of the flower, as well as the touch of its petals against the skin. And during this process, patients are guided to cultivate a metacognitive reflective attitude and to become aware of the arising of positive emotions in the mind or pleasant sensations in the body, and then to focus on these pleasant feelings and to magnify them and absorb them and allow them to expand. Then they're asked to practice this technique with naturally occurring pleasant everyday objects and events that they encounter in their life. And this technique is intended to amplify natural reward processing in the brain, boost positive emotions, elicit meaning in life, and cultivate experiences of self-transcendence, the sense of interconnectedness between the self and the world. So through this integration of mindfulness, reappraisal, and savoring practices, MORE aims to modify associative learning mechanisms that have become hijacked during the allostatic process of addiction by strengthening top-down cognitive control functions to restructure bottom-up reward learning from valuing drug-related rewards back to valuing natural, healthy rewards. And this therapeutic focus accords with what I call my restructuring reward hypothesis, which states that shifting valuation from drug-related rewards back to valuing natural, healthy rewards will reduce craving and addictive behavior. And in my view, not only as an addiction scientist and a chronic pain scientist, but also as a clinician working with people with these conditions for more than 2 decades, I think this is really the essential therapeutic task in recovery. The person in recovery from addiction must relearn what is and what is not important in life, what is and what is not meaningful in life. And they must reclaim that sense of meaning that had been hijacked from their people, their activities, their values that they once cared about, and then reinvest that sense of meaning back into those people, activities, and values to re-imbue these parts of their life with meaning and purpose. And this is an important therapeutic focus for the mindfulness-oriented recovery enhancement intervention. So MORE is an evidence-based treatment, and recently a meta-analysis was published of the randomized controlled trials of MORE, and it was shown that MORE produced statistically significant effect sizes in reducing addictive behaviors, psychiatric symptoms, and chronic pain relative to a wide array of active control conditions with effects persisting at long-term follow-up. I want to highlight some of these studies here, and I want to move through them somewhat chronologically to give you a sense of the evolution and the development of the MORE research program. So the first study I want to highlight is the first NIH-funded randomized controlled trial of MORE as a treatment for chronic pain and opioid misuse. In this study, there were 115 chronic pain patients who had been taking opioids for about 10 years. At the beginning of the study, about 3/4 of the sample reported misusing opioids, and there were high rates of comorbid psychopathology in this sample as well. These patients are randomized to receive 8 weeks of MORE or 8 weeks of a supportive group psychotherapy control condition. In summary of the findings, we found that MORE led to significantly greater reductions in pain-related functional interference and pain severity than the control group. Importantly, we found that the effect of MORE on reducing chronic pain severity was statistically mediated by this capacity to reinterpret pain as harmless sensory information. So the better able patients were able to see their pain, not as this terribly emotionally anguishing experience, but rather as sensations of heat or tightness or tingling, the greater the pain relief they achieved. In this study, we also found that MORE reduced opioid misuse. There was a 63% decrease in opioid misuse symptoms consistent with having an opioid use disorder in the MORE group, compared to a 32% reduction in the supportive group psychotherapy control condition. And I would add here that our control condition was obviously an active treatment. It was reducing opioid misuse, but MORE was mo better. And sorry for the terrible pun, but when you have a therapy called MORE, there's no end to the puns you can make. There's always more and more. Now my kids would be accusing me of a dad joke at this point. So we attempted to measure hedonic dysregulatory mechanisms and MORE's impact using the dot probe task that I described to you earlier. And we found the first evidence in the scientific literature from a randomized controlled trial that a mindfulness-based intervention could reduce the pain attentional bias. So after 8 weeks of treatment with MORE, patients' attention was less hyper-focused on, less biased towards pain-related information. We also found that among patients with an opioid attentional bias, MORE significantly decreased that bias. And we recently replicated these effects in a much larger randomized controlled sample, showing the same phenomenon that MORE significantly decreases the opioid attentional bias. So after 8 weeks of mental training with MORE, patients' attention is less triggered by, less captured by opioid-related cues. But some of the most interesting data in this study came from heart rate collected during the dot probe task. You can see here that across all 3 cue conditions of the dot probe task, MORE produced significantly greater heart rate decelerations than the supportive group psychotherapy control condition. Not surprisingly, the more patients' heart rate slowed as they viewed the opioid and pain photographs, the less aroused, the less stimulated the less triggered they felt by those images, and that made perfect sense. But we found the opposite pattern in response to the pleasurable photographs. The more patients' heart rate slowed in response to the pleasurable photographs, the more aroused, the more stimulated they felt by these images. And so we took this to mean that potentially more was increasing physiological sensitivity to natural rewards. We conducted a heart rate variability analysis and found that across the board, more led to significantly greater heart rate variability than the control group, but this effect was most pronounced to the pleasure cue condition. So we wanted to understand the clinical implications of these findings, and we conducted a multivariate path analysis and found that the effect of more on reducing opioid craving was statistically mediated by changing the heart rate response to the pleasure cue condition, not by changing the heart rate response to the opioid cue condition. So in other words, more was decreasing opioid craving by enhancing natural reward processing. And this represented the most profound, really the most important scientific finding of my career up to this point. And I think you can appreciate this if you recall that the prevailing model of addiction neuroscience states that as people become more and more addicted, they become less sensitive to natural, healthy pleasure, and this drives them to take higher and higher doses of the drug to feel okay. These data suggest that this allostatic process might be reversed, that by teaching people how to mindfully savor natural, healthy pleasure, this may reduce the pull of drug-related rewards and thereby decrease craving and addictive behavior. And I think it was probably this finding that led to the subsequent funding of more than $30 million worth of federal grants to study more in this mechanism. In this study, we also collected ecological momentary assessments. So we asked patients to rate their pain and their mood state up to 3 times a day, each day when they took their opioid medication. And this produced a tremendous amount of data, so 224 time points per individual. And we found that more was decreasing pain from moment to moment in everyday life. We also found that more was increasing positive emotions from moment to moment in everyday life. In fact, patients treated with more had 2.75 times the odds of those in the control group to be positively emotionally regulated over the course of treatment. And interestingly, it wasn't the decreases in pain that predicted reduced opioid misuse, but rather patients who showed the largest increases in momentary positive emotions reported the greatest decreases in opioid misuse. And this provided some additional initial support for my restructuring reward hypothesis. This notion, again, that helping people to shift from valuing the drug back to valuing natural, healthy pleasure and positive emotions may reduce addictive behavior. So given these promising results, we wanted to replicate them. So we conducted a second stage 2 randomized controlled trial of more in a primary care context. And once again, we found that more led to significantly greater reductions in pain severity and significantly greater reductions in opioid misuse than a supportive group psychotherapy control condition. In this study, we also showed that more increased an array of positive psychological functions, including positive affect, savoring, meaning in life, and self-transcendence. And importantly, the effect of more on reducing chronic pain severity and opioid misuse was linked with increases in these positive psychological functions, suggesting that one way to treat the disease of despair is to teach people how to mindfully savor natural, healthy pleasure, joy, meaning, and self-transcendence in everyday life. And in this study, we also found that more decreased opioid use. So there was a 32% reduction in opioid dosing by the 3-month follow-up point. We wanted to understand how more was producing this opioid dose reduction. And so we brought patients into the lab and we had them practice mindfulness meditation while we recorded their heart rate variability. And we found that the effect of more on reducing opioid use was statistically mediated by increases in parasympathetically mediated heart rate variability during mindfulness meditation. Given the known linkages between high-frequency heart rate variability and self-regulatory capacity, it seems that patients are learning how to reduce their opioid use by increasing self-regulation of their autonomic responses during mindfulness meditation. So around the same time, we were also interested in whether more could improve outcomes among patients being treated with medication-assisted treatment for opioid use disorder. So my colleague Nina Cooperman at Rutgers University and I were awarded an NIH grant to conduct an early-stage randomized controlled trial of more as an adjunct to methadone treatment for patients with opioid use disorder in the community. We didn't really expect to see a significant result in this small early phase pilot trial of 30 patients. And these were patients, I forgot to mention, that were from the inner city of New Brunswick, New Jersey. This was a largely African-American and Latinx sample with a relatively low education level. But much to our surprise, we found that more led to significantly fewer days of opioid use, significantly fewer days of drug use, lower levels of chronic pain and depression compared to methadone treatment as usual. In this study, we also used ecological momentary assessments. And so we pinged people's smartphones several times a day and asked them to rate their opioid craving and their mood state. And we found that more decreased the intensity of opioid craving by 50% by the end of the treatment. We also found that more increased momentary positive emotions. And once again, increases in positive emotions were associated with decreases in opioid craving, providing additional support for my restructuring reward hypothesis. So we always like to replicate our work, and we scaled this trial up to an NIH R33 grant to replicate this trial in a larger sample. This trial started at the onset of COVID-19, unfortunately, so we had to rapidly pivot to delivering more over telehealth through Zoom. And we actually just finished this trial. We just got the results. They're currently under review at a good journal, and we're hoping to hear back any day now with an acceptance. So the results are really, really quite impressive. So we found that relative to methadone treatment as usual, that giving patients additional therapy with more resulted in significantly fewer days of opioid use, significantly fewer days of drug use, and also patients treated with more had a significantly lower rate of relapse back to drug use than addictions treatment as usual. More also improved adherence to methadone treatment and more decreased chronic pain intensity more than addictions treatment as usual. So these data really do suggest that this is a potentially efficacious intervention for the treatment of opioid use disorder. So given all of these really exciting studies and evidence of Moore's potential clinical efficacy, we wanted to start getting under the hood and understanding the neurophysiological mechanisms by which Moore was producing its treatment effects. So in another sample of chronic opioid users, we brought them into the lab and had them participate in an opioid cue reactivity test while we recorded EEG to obtain event-related potentials. And here in the red line is the brain's response to viewing opioid cues before treatment. And here in the blue line is the brain's response to viewing opioid cues after 8 weeks of treatment with Moore. The gray lines represent the brain's response to viewing neutral cues. So you can see that Moore significantly decreased the late positive potential of the EEG during viewing of opioid cues, in effect making the opioid cue more neutral. And on the right, you can see ERPs from patients undergoing standard group therapy. Here you can see really no difference at all. And if you have trouble reading this EEG, here's a bar chart that shows the effect, a massive decrease in brain drug cue reactivity occasioned by Moore. This is the first evidence from a randomized controlled trial that a mindfulness-based intervention can reduce drug cue reactivity in the brain. So given the novelty and the clinical significance of these findings, they were published in the high-impact journal Science Advances a couple of years ago. And one of your T32 graduates, Rachel Ashley, was a key author and contributor to this study. So grateful for her help and her training with you guys. But we've also found that Moore increases neurophysiological responses to natural healthy rewards, as indicated by the late positive potential of the EEG, as well as skin conductance responses during viewing and savoring of natural reward cues. In addition, we found that Moore increases positive affective responses on the positive emotion regulation task while patients viewed and savored naturally rewarding images of smiling babies, lovers holding hands, beautiful sunsets. Patients just reported feeling happier in viewing these images. And the effect of more on reducing opioid misuse was statistically mediated by increases in these positive emotional responses. And these data again provide support for my restructuring reward hypothesis. This notion that if we can teach people to become more sensitive to natural, healthy pleasure, this may reduce the pull of drug-related rewards and thereby decrease addictive behavior. And so these data bring me to the largest randomized controlled trial of more conducted to date. This was a NIDA-funded R01 grant. We finished it a couple of years ago. We published it in the top journal, JAMA Internal Medicine. In this study, there were 250 chronic pain patients, all of whom were prescribed opioids and all of whom were misusing opioids as an inclusion criteria to enter the trial. They were randomized to receive 8 weeks of more or 8 weeks of a supportive group psychotherapy control condition. We delivered these interventions in the primary care clinics, in the same clinics where patients were receiving their opioid pain management. Patients reported pain levels of about a 5.5 out of 10 and had been in pain for about 15 years. They were taking high opioid doses at baseline, about 100 morphine milligram equivalents a day on average. There was lots of chronic overlapping pain in this sample, so 3/4 of the sample reported having 2 or more chronic pain conditions, and there were high rates of psychiatric comorbidity in this sample, with nearly 70% meeting criteria for major depressive disorder, 62% had a full-blown opioid use disorder, 21% had a non-opioid substance use disorder, and there were high rates of generalized anxiety and PTSD as well. And so in summary of the findings, we found that more reduced opioid misuse by 45%, nearly tripling the effect of standard group therapy at the 9-month follow-up point. And in this study, we measured opioid misuse quite robustly by using a measure that triangulates self-report, blinded clinical interview, and drug urine screen. In this study, we also showed that more significantly decreased opioid dosing through the 9-month follow-up point. And 36% of patients treated with more were able to cut their opioid dose in half or greater. At the same time, more significantly decreased opioid craving from moment to moment. So these data indicate that more is a highly efficacious treatment for opioid misuse and may also be useful in helping patients to taper down their opioid doses. And what was particularly interesting about that finding was that in this study, we didn't push patients to cut their opioid use. They weren't asked to taper their opioids. Patients just did this on their own accord as a function of learning the skills in the more intervention. And in this study, we also found that more significantly decreased chronic pain symptoms and emotional distress. 50% of patients treated with more reported clinically significant reductions in pain severity. And the effect sizes that we observed for more exceed those that are typically found for cognitive behavioral therapy, which is the current gold standard psychological treatment for chronic pain. And in addition, more produced a wide array of benefits in terms of psychological health. So recall that about 70% of the sample met criteria for major depression at the beginning of the trial. Well, at the 9-month follow-up point, patients treated with more no longer had depression symptom severity levels that surpassed a validated cut point for major depressive disorder. So more had really robust antidepressive effects. Also, more produced effects on reducing PTSD symptoms. These findings were recently published in the journal Nature Mental Health. We found that 59% of patients who surpassed a cut point for PTSD reported clinically significant reductions in PTSD symptoms following treatment with more. And at the same time, more enhanced an array of positive psychological qualities, including positive emotions, meaning in life, and self-transcendence. So these data suggest that more is a broad spectrum treatment that can actually not only address chronic pain and addictive behavior, but the psychiatric conditions that are often comorbid with these problems. I like to replicate my work, and so we had the opportunity to do so in a large DoD-funded clinical trial. So we just finished this trial up this year, and In this study, there were 230 veterans and active duty military personnel with chronic pain who were receiving long-term opioid therapy. These folks also had been in pain for about 20 years and were taking high opioid doses at baseline. And once again, we found that more significantly outperformed supportive group psychotherapy on reducing chronic pain symptoms and opioid dosing through an 8-month follow-up. There was a 21% reduction in opioid dose in the Moore group compared to a 4% reduction in the supportive group therapy control condition. And at the same time, more significantly decreased opioid craving and reduced pain catastrophizing and anhedonia and enhanced positive emotions as well. So these results were just accepted for publication in the American Journal of Psychiatry and should be coming out in a month or two. So we're really excited about these results. So replicating these findings across 2 large-scale clinical trials really adds confidence that Moore is a highly efficacious treatment for this comorbidity of chronic pain and opioid use and misuse. But we've also shown that Moore increases internal healthy reward responses. And this measure, I think, depicts this phenomenon quite well. So this is a body map developed by my colleague Adam Hanley and myself. And on this computerized body map, patients locate pleasant and unpleasant sensations. Pleasant sensations are represented in blue, unpleasant sensations are represented in red. And this is a one-sided body map, so it represents the summation of sensations on the front and the back of the body. And I don't really think you need to know any statistics at all to see there's a huge effect going on here. So you can see that Moore massively increased sensations of pleasure in the body and powerfully shifted the ratio of pleasant and unpleasant sensations. So at the beginning of the study, patients reported experiencing about 1 pleasant sensation for every 4 unpleasant sensations. And that I just find really sad. I mean, I think it speaks to how much these folks are suffering. But by the 6-month follow-up point, patients in Moore reported experiencing 2 pleasant sensations for every 1 unpleasant sensation. So Moore just powerfully shifted the sense of embodied self-representation and really transformed the sense of the body as being this place of anguish to becoming this place of refuge. So finally, we were interested in whether deep meditative states leading to the experience of self-transcendence might have anti-addictive properties. So to answer this question, in a mechanistic randomized experiment, we took patients undergoing Moore or supportive group therapy. We brought them into the lab and had them practice mindfulness meditation while we recorded EEG. And we found that patients treated with Moore showed significantly greater increases in frontal midline theta power and coherence during mindfulness meditation relative to supportive psychotherapy. And patients who achieved the deepest states of self-transcendence during mindfulness meditation showed the highest levels of theta during meditation. And the effect of Moore on reducing opioid use through a 4-month follow-up point was statistically mediated by increases in this frontal midline theta power. And this is interesting because, as some of you may know, frontal midline theta is a well-known biomarker of cognitive control. But it also increases during states of flow, when the sense of self is suspended and transcended during deep cognitive absorption with ongoing experience. So these data suggest that mindfulness meditation may provide a means of endogenous theta stimulation of the prefrontal cortex, and thereby enhance inhibitory control over addictive behavior. And we recently replicated these results as well in the largest neuroscientific study of mindfulness as a treatment for addiction. These data were published in the top journal Science Advances last year. And again, this was a randomized trial comparing patients who were being treated with mindfulness-oriented recovery enhancement to patients being treated with supportive group psychotherapy. And the design was very similar to the last study. We brought them in at pre and post treatment and asked them to practice mindfulness meditation in the lab while we recorded EEG. And I love seeing data like this. You really need no statistics at all. So here's the game. The game is which one of these 4 images is different from the others. And it's pretty obvious, right? I mean, dramatic effects following more in terms of frontal midline theta activation in the brain. Once again, higher levels of frontal midline theta were associated with self-transcendent experiences and mediated the effect of more on reducing opioid misuse through a 9-month follow-up point. So replicating the same pattern across 2 independent randomized controlled trials with 2 independent samples suggests that we may have indeed found a crucial mechanism by which mindfulness can reduce addictive behavior. So in summary, we see that more decreases addictive behavior, drug cue reactivity and craving, and at the same time, more reduces physical and emotional pain. But more also has the capacity to increase healthy positive emotions, the sense of reward and meaning in life, and more appears to produce these effects by strengthening self-regulation and eliciting self-transcendent experiences. Taken together, this body of work supports my restructuring reward hypothesis, which suggests that increasing sensitivity to natural healthy pleasure, meaning, and self-transcendence may come to outweigh the pull of drug-related reward and thereby reduce addictive behavior. So in conclusion, more is an efficacious treatment for addiction, emotional distress, and chronic pain, as demonstrated by about 12 randomized controlled trials now involving more than 1,300 patients to date. We've learned a great deal about how more works over the past decade. More's mechanisms of action include reducing drug cue reactivity, enhancing natural reward processing, strengthening self-regulation, and eliciting self-transcendence. And given that, really, I think this robust evidence for More's efficacy, I think it's time to disseminate this therapy now and bring it out into the real world. And so a lot of my energy is being focused on that lately. So I've trained more than 850 clinicians from around the US and internationally to deliver this intervention. And these folks are in fact delivering more as part of their clinical practice. Some people are actually achieving insurance reimbursement for delivering more, for example, as a medical group visit. Also, given More's efficacy, I think it's time to consider how we can optimize the therapy. Certainly, this is an efficacious treatment, but it doesn't work for everyone. And so I'm interested in extending its reach and impact by integrating More with other neuroscience-informed therapies like neurofeedback, neurostimulation, and psychedelics. Ultimately, teaching people to take in the good and mindfully savor natural, healthy pleasure may provide the learning signal needed to restore adaptive hedonic regulation and ultimately to reverse addiction. And I know that's a bold claim, but we're really facing a serious crisis in this country. And so I sincerely hope that this line of work has made a positive impact in that regard. So I want to thank you for your attention. I want to thank the funders of this work, including the National Institutes of Health and the Department of Defense. I'll call your attention that the next More training is being held online by Zoom on December 1st and 2nd. So if you're interested, just reach out to me. And it looks like we have plenty of time now for questions. So I'm happy to answer any of your questions. And thank you. And now I can't hear you. Now I can.
Should we clap again?
That was an impressive overview of More. This is a very impressive collection of published papers and trials you've had. So congratulations, Brian, very impressive. On your map of where you have the providers, I was thinking very selfishly, it didn't look like in Oregon. I'm not sure Portland was, so you have no more providers in Portland? Or is it just a bad, it may not be an accurate map. I was trying to think, it looked like it was closer to Eugene and Salem.
You know, I don't know the answer to that because I trained so many folks that it's not off the top of my head, but we certainly need more folks in Portland.
I think there are probably people at this table who would might benefit, but in any case, it would be, anyway, it's nice that you sort of gave this opportunity if people want to do the Zoom training. So I'll turn it over to questions now.
Thank you.
Hi, Eric. Thank you so much. I had a question about difference in effects when it's in person versus online. So you had that kind of opportunity to do it virtually during the pandemic. Did you ever look at that? To
Great
compare
question.
in person and online?
Yeah, great question. So we do have the opportunity to look at that to some extent in from a more meta-analytic frame. We're not going to be able to do that within a particular trial because the only trial where we delivered more both in person and online was my DoD funded trial, which we just finished. But the sample size is not. It was 230, but that doesn't really give us enough power to look at it's not full test delivery format as a treatment response moderator. But I do think that if we pull the data out and look at it analytically, I think we can look at differences in online versus person across studies. I can tell you that it looks like more works telehealth. It may not work quite as good, but we'll let the meta-analysis tell us.
Thanks.
Questions? Have you had the opportunity to look at other forms of addiction using more?
Yes. So we are currently finishing up in our one treatment for smoking cessation, and this is a mechanistically trial. It's using fMRI, and we compared more to cognitive behavioral therapy. And we're just finishing the study now, so I have no idea what the results are. so I can't tell you. I can't tell you whether it beats CBT or not. I do know that patients in both arms are quitting smoking at pretty high rates. So something's working, but not sure what it is yet. We've studied more for general substance use disorders, so patients in inpatient treatment programs with addiction to a wide array of different substances. And we published these results in 2016, showing that more actually produces larger reductions in craving and PTSD symptoms than trauma-focused CBT intervention. But that study had a pretty big sample, about 180 participants, but again, not enough in any one subgroup to be able to say that more is definitely efficacious for a different type of drug. So I know right now the methamphetamine epidemic is really brewing, and it's a big concern, big public health concern. So personally, I would be interested in looking at whether more can make a positive impact for that form of addiction, but we haven't done that yet.
Thank you. There's a question in the chat from Ben Marasco. Ben, would you like to just unmute yourself and ask a question? Otherwise, I can read it.
Eric, that's a great talk. Thank you. I was just wondering if you could say more about treatment moderators. You implied a little bit about that in one of your slides at the end. Just, it's just such a topic in the pain world about factors that who may or may not be most likely to benefit from an intervention. I was wondering if you could say more about the techniques done for that.
Yeah, that's a great question. My short answer is yeah. My long answer is in the meta-analysis, the Parisi meta-analysis, they looked at gender and income and race as moderators, and none of which moderated Moore's treatment impact, which that, to me is really good news, because it says that this intervention is accessible to a wide array of different groups of people. But then it begs the question, well, how do we then understand who's going to respond and who's not? And that's a question that really interests me a lot. So we haven't done any. I think to really answer the moderation question, right, you need a really large sample. But now we're approaching that by having so many clinical trials that basically have the same research design, the experimental intervention, the same control intervention, that if we pool data across studies, we can use meta-analysis to look at treatment moderators. And so that's in the works. That's one of the next steps for this line of research. But I don't know. The guess is as good as mine at this point.
Thanks, Art. Or you can go in with the idea that it seems to benefit most people is a fine interpretation as well. Thank you.
So question in the group.
I do, to finish on that topic, I do think it's really interesting to note what's particularly interesting. So we deliver more as group therapy. And let's say you have 10 people in the room. Let's say it's the very first session where we teach the first mindfulness skills. And inevitably, there's one person in that room who achieves complete cessation of pain in the very first mindfulness practice. And this is somebody who has, been suffering from pain, let's say 8 out of 10 for 15 years. They practice mindfulness for the first time ever, and they come out of that meditation and they say, that is clinically, that's just fascinating. Like, what is it about that person that enables them to go so deeply into the meditative state that they achieve this pain relief? I have no idea. I have some guesses about it, but I think that makes for really scientifically important and clinically important questions. So, love to explore it.
I was wondering about the home practice, because I noticed that people are supposed to be practicing for 15 minutes every day. And I'm wondering, like, are people really doing that? And two, if you notice any like effects for, like, if someone practices twice a week, do they still get the benefits of the intervention, or are they really needing to be practicing it every day to notice them home?
It's a great question. You guys and your good questions, you should come analyze my I mean, my answer to that is that there's a lot of variability in practice. Some people practice a lot, some people don't practice at all. And of course, all the results that I presented to you today is I'm giving you the average effect, averaged across all this variability in terms of practice. So, but so we actually have a ton of this practice data. We have a bunch of cool data that we haven't published yet. Ecological momentary assessment data where patients are recording the amount of practice they do each day and reporting their symptoms several times a day. So that's something that I hope to model and publish the next year or two is the impact of practice. I can tell you I've looked at those data and not surprisingly, the more you practice, the better of a result you get. But your question is really good. What is that minimum threshold of practice that people need to do in order to benefit? And I don't know what the answer is. So if you're good at EMA, shoot me an email. I've got a paper for you to write.
Have you thought about applying this as more of a prevention intervention, like with teenagers who are using substances or have chronic pain, or young adults who are doing some substance use but not meeting criteria?
It's a great idea. We've done some initial work in that direction. We took 4 skills of mindfulness, reappraisal, and savoring, and we developed a very simple intervention package, and we presented it to a local high school. We did a quasi-experimental study of this abbreviated, we can call it an abbreviated MORE type approach. We attempted to follow kids when they went to college and ask them about their drug use. So that study is close to being done, so we should have some results soon. So I can't say what it's going to show, but I think that would be a great application for this. Essentially, it would have to be a modified intervention, obviously, because a lot of the psychoeducational content is directly speaking to addiction or chronic pain, and maybe some of these kids haven't developed those problems yet. So So some of the psychoed pieces might need to be adjusted, but I think it could hold some promise there. And I'd love to see more work in that area, and that's not really my expertise, research with children and adolescents. Hopefully somebody else will do that work.
Yeah, thanks for a great talk. I mean, in the context of adolescents and teenagers and so on, do you think this might be worth looking at this for cell phone addiction, for example? So what about being on your phone all the time? Like replacing it with other activities?
No, because they still need that social, they'll be all left out.
Eric, did you get that question?
No, what was the question?
No, I was just asked whether you thought this might work for teenagers who are addicted to their cell phones. And not just teenagers.
I don't know. It hasn't worked for my addiction to my cell phone yet. But no, in all seriousness, a PhD student at UNC Chapel Hill, she did her dissertation on more as a treatment for video game addiction in college students, and it worked. More significantly reduced DSM criteria for video game addiction, and also significantly decreased craving for video games. Those data were published a while ago now. I think back in 2017 or 2018. And that was a small study. It was an N of 30, and we saw effects even in an RCT with an N of 30. So I'm kind of bummed out that actually no one's ever followed that up with a big trial, because I think it's really needed.
Thanks. Another question.
So my area of research is in self-transcendence, and I'm familiar with your NADA scale, which I think is fantastic. I'm curious about your thoughts around like the savoring and the natural healthy pleasure and the self-transcendence and their relationship. Is it one, is the experience of the pleasure mediating the self-transcendent experience, or is it the other way around, or maybe both? Just curious about your thoughts on that.
Thank you for that. I have a lot of thoughts on that subject. And I'd probably be afraid to share those thoughts anywhere but to a group of integrative medicine researchers. No, but the way I think about this is essentially is that savoring is one path to self-transcendence. I mean, there are other paths, but when we savor, let's say we savor a beautiful object like a rose, for example, and I'm holding it in my hand, and I'm bringing my attention to this object. What I'm really savoring, if you think about it at a deeper level, is I'm savoring the contact between the subject and the object. So I'm focused on the color. I'm focused on the scent. I'm focused on the touch of the flower against my skin. I'm focusing on where the subject makes contact with the object, and really focusing intensely on this point of contact. So in a sense, without sounding too metaphysical, even though I like to get metaphysical, that when you're savoring this point of contact between the subject and the object, you're very literally savoring the sense of oneness between the subject and the object. And so therefore, this could potentially lead to a transcendence of this normal subject-object dichotomy. And incidentally, the related question is, especially for you EEG researchers, why are we seeing increased frontal midline theta associated with self-transcendence, when frontal midline theta is something that increases pretty reliably during cognitive control tasks, where you're having to focus and screen out distractors? When you're able to do that effectively, there's an increase in theta. So what does that have to do with self-transcendence, right? It's another interesting question. And what I tried to articulate in my Science Advances paper was that in order to become deeply focused, to the point at which we can screen out distractors, there is this absorption of the subject, the observing subject, on the attentional object. And so hypothetically, when that attentional absorption reaches its zenith, so to speak, then there is no more, the subject becomes so focused on the object that the absorption is complete and there's no distinction between the subject and the object. So, and you need a lot of cognitive control resources to be able to do that kind of focus. And so I think the same thing is going on in savoring. And interestingly enough, classically, in some Tibetan Buddhist, according to some Tibetan Buddhist teachers, like Tsongkhapa, it was observed, it's been observed for a very long time that it's easier to focus attention to have to perform shamatha on positive objects, because we like to focus on positive objects. They attract our attention. So it actually makes a very powerful means of attentional concentration that can lead to samadhi. How's that for an answer?
That's great, thank you.
Yeah, fantastic answers. So we have a question from Dr. Lynn Shinto. Lynn, would you like to unmute yourself and ask the question?
Sure. Hi, Eric. Really fantastic presentation. So I might have missed this, and I apologize if I did, but I was just wondering, how long are the benefits sustained?
Thanks for the question, Lynn. So the longest that we've gone following up for follow-ups is 9 months post-treatment. So that's about 11 months from the beginning of the baseline assessment. So that's as far as we've gone so far.
So as a follow-up to that, are the participants actually maintaining their practice for that 9 months? Do you think, is that something you've been able to follow?
It's a great question. I get asked that question very frequently when I give this talk, and unfortunately, we did not measure practice that long. So we asked patients to record their practice very fine-grained way on a daily basis for 90 days following the end of the intervention, and then we figured we had bugged them enough and we didn't want to burden them. But I regret that, to tell you the truth, because I really want to know when they're continuing to practice. And if you recall the effects on that JAMA paper, the effects are not getting weaker by the 9 months. They're actually either getting stronger or at least maintaining at the 9-month follow-up point. So that really, that suggests that people are continuing to practice. And it also makes me wonder, asking here, how long do the effects last?
Yeah, that's great. Any more questions?
It was a fascinating series of studies here, by the way, and information. So thanks again. But I'm interested in the physiologic markers. And so you do have these ERP markers for sort of reactivity to visual stimuli, which in and of itself is fascinating. But MCGH, or NHS, had a conference on interoception. And I was wondering if you've thought about thinking about some kind of interoceptive stimuli and looking for whatever sensitivity or reactivity to that would be. Thought about. And whether it would be affected by it. My sense is it would be.
Yeah, great point. And obviously this issue of interoceptive awareness and exposure to the body sensations is key to how we're treating pain and craving, or at least we think it is. So I currently have an R01 from NCCIH to do thermal pain stimulation, which isn't quite, it's debatable how interoceptive is really at the skin. But do thermal pain stimulation with chronic low back pain on opioids, they're receiving more, and we're doing some fMRI while they're getting this thermal pain stimulation. So that study's going on right now, and I'm pretty excited about it. We have a ways to go. I think we've enrolled about 50 patients so far. So we're about a third of the way done. But hopefully we'll know something in a couple of years. But I'm also interested in more classic interoceptive tasks and interoceptive probes, really getting deeper into the body, into the viscera, and could more impact that too. And I don't know.
So you've been sold by NCCIH. I was just talking to Anna Wilson, who asked one of those questions. So she's doing thermal pain. So it's a useful marker, but NCCIH somehow signed off on these tactile stimulation as being a marker for interoception. And I'm not sure there's a neural basis for that concept, but you can't get funded for it for NCCIH. But I think it is interoception. But I mean, I think there are other approaches, and it does seem that it would be however you can think about it, it would be nice to come up with some measure. And we've thought about different ways. I mean, obviously tactile stimulation is certainly one. It is tricky to come up with these deeper presentations. Somebody was insufflating fluid into the bladder to sense bladder fullness. These are not insignificant studies. So there are.
Yeah, actually, I in my work as a T32 student at UNC, I was working with Susan Gaylord, who I don't know if you know her, but she had an R21 to study mindfulness as a treatment for irritable bowel syndrome. And I was involved in that trial as a PhD student, and it was a fantastic experience teaching me how to do clinical trials of mindfulness-based therapies. And incidentally, it totally worked. Mindfulness significantly decreased IBS symptom severity. So the logical follow-up study that I thought would be fascinating to do is to do the balloon distension test, which they do for IBS, which is definitely visceral and definitely interoceptive. But I don't think anybody's done that yet. It's a great study to do. Also, I'm not sure if you are familiar with Fadel Zaidan, who's a great friend and colleague of mine. He was one of your predecessors. We had him 2 years ago or something. He was one of our keynotes. I can have some people, good people. So yeah, he has used a task, a very ecologically valid task for chronic low back pain, where he's doing a straight leg raise test on people with low back pain to actually activate their chronic low back pain. And that's both, I think, an interoceptive task as well as a very ecologically valid one. So his study recently finished, and his results should be out of the literature soon. Yeah, that's a great one, because that is ecologically valid, as you said. It's hard to get the ecologically valid, sort of pain, interoceptive. Exactly. Yeah, I really don't know. In my study, I have no idea if it's going to work, because we know very clearly that more is reducing chronic pain, but whether it's going to reduce the acute thermal pain on the skin, no clue. I guess that's why we're doing the research, right? Find out. Got to do the experiments. Okay, so hang around just in case people want to talk, more one-on-one, but otherwise I'll close it off so people can finish and chat among yourselves, I guess, and give Eric a final round of applause. Thank you.